Hi, this is Courtney. I am joined here today with Dr. Pisano, and we are going to be discussing a common question that we have seen come across a lot of our platforms, which is delayed reconstruction and the final results. For so many patients right now who are having to delay their breast reconstruction surgery because of the coronavirus outbreak, there's just a major concern for a lot of those women on what their final results are going to look like, since they no longer can have immediate reconstruction. So Dr. Pisano, can you just kind of expand on that a little bit?
Yeah, that's a great question. Many women are going to have their therapeutic mastectomy in the absence of a reconstruction. If they're in a geographic area where reconstruction is having to be postponed because of the COVID-19 situation. So what we're going to do in our practice is make every effort to get those patients to their reconstruction as soon as possible. If we can do it in a matter of weeks to months, the tissues of the chest wall will be soft enough that they can accommodate a flap or an implant or whatever we choose to use. And I think we can still get a really nice result. Obviously, an immediate reconstruction is optimal, but there are going to be a great number of patients who don't have that option and need to move forward with their mastectomies as soon as they can.
Now, is there something that you, as a surgeon, do in the OR in a delayed setting that can help optimize the final result outcomes for flap and implant reconstruction patients?
Well, we do a lot of delayed reconstructions as a matter of routine. So we just, in plastic surgery speak, we recreate the defect on the chest wall, expand the skin there as best as possible so that it will fill up nicely with our soft tissue. Patients could go to our website and see examples of delayed reconstruction. So just as a matter of course, we're experienced in doing that. And again, because of the situation, we'll probably have to do more of that than we ordinarily would. But again, we'll get to those patients as soon as we can, before the skin's had a chance to sit down on the chest wall and contract and become less pliable.
In a situation, we know this isn't possible everywhere because geographically, every area that's being impacted by coronavirus is different. So different hospitals are doing different things and setting different guidelines. Yeah. But in a situation where a patient has the option to place a tissue expander at the time of a mastectomy, is that a good option, or would you recommend that in place of immediate reconstruction? And what are the pros and cons to that?
Yeah, well, that's a great question, and a controversial one. The benefit is you put the tissue expander in, and it acts as a spacer to, again, in past plastic surgery speak, keep the skin out to length so that it retains that rounded or teardrop shape. So that's the pro. The con is tissue expanders have a known complication rate. And so by putting in tissue expanders in everybody, you may encumber complications like infection and exposure of the implant, fluid collections around the implant. So it solves one problem but can create others. In our geographic area, placing a tissue expander is, for the most part, right now considered elective and to be postponed. There are some scattered exceptions to that have to do with those women who might be able to proceed with a mastectomy even during the COVID shutdown of elective cases. But in our practice, to finish the point and to really answer your question, we've decided not to do that because the Texas Medical Board has advised us not to do that. And our local hospital wants us to preserve PPE, the materials that they might need to treat COVID patients for that purpose. And so for those reasons, we've decided not to put in tissue expanders.
What about women who are interested or are candidates for nipple sparing mastectomy? Is a nipple sparing mastectomy still an option, even though they're going to have to delay reconstruction during this time?
Well, another good question. Many of the general surgeons that we work with in our area will do a nipple sparing mastectomy in the setting of a delayed reconstruction. For example, a patient who is a candidate for nipple sparing mastectomy because of the location and size of the tumor, but who needs postoperative chemotherapy, but more typically radiation therapy. Maybe they have multiple positive axillary nodes or something. So general surgeons here will often do a nipple sparing mastectomy. The tissue sits down on the chest wall, and then we come back and we do our delayed reconstruction as we would any of our usual delayed reconstructions. So that can be done. It is done in our area. Patients coming from other states or other cities in Texas could certainly discuss that approach with their surgeons. Yeah, that's a great question.
Very nice. And this may also be a controversial question, but a good one, and one we have seen a few times come across on a lot of our platforms. But when we're discussing lumpectomy versus mastectomy, and in this time period with the coronavirus and there's so many what ifs and surgery being delayed, for women who really want to do immediate reconstruction at the time of their mastectomy, if it is clinically acceptable, would a lumpectomy be a better option to start cancer treatment and then follow later with the mastectomy and immediate reconstruction? And if so, what does that do to impact breast reconstruction results?
Yes, a very good point. And it may be some women are a candidate to have a partial mastectomy or a lumpectomy to kind of tide them over if what they're really seeking is a mastectomy, because then the majority of the breast is intact and the skin envelope over the breast is again out to length. And so that buys time. The acute cancer is out. So that's definitely a good option for a smaller tumor, a stage 1 tumor that's in a favorable location, maybe upper outer area of the breast, for example, which is a favorable place for lumpectomy anyway. And then they can come back and have a completion mastectomy, and maybe with a prophylactic mastectomy on the other side if there's a family history or a genetic susceptibility component. So that's certainly one way that women can, in essence, get an immediate reconstruction.
Very nice. And then just to kind of wrap up our conversation today, can you give us some updates on specifically what's happening in San Antonio as it relates to coronavirus outbreak and our efforts with keeping patients safe and our staff safe during this time?
So as of this morning, the San Antonio Metropolitan Health District has reported 503 cases. In San Antonio, there have been, unfortunately, 12 fatalities. Overall, San Antonio was behind the rest of the nation, certainly New York City and parts of the West Coast. We think that the peak of the curve is coming in the next week or so. So San Antonio is in a favorable position relative to other parts of the country as it stands right now.
Wonderful. Thank you for that update. All right. Well, have a great afternoon.
Same to you. Thank you for some great questions. I hope people derive some benefit.